Just 1 second.
Everyone will be starting in another next 2 minutes. I would
Two
request
minutes? Okay.
everyone to be online with us.
Shwani, you are now secretary of CIASM, right?
Yes, sir. It's been 3 years. My last year, actually.
Okay.
Which body is this?
The Southeast Asian Academy of Sleep
Oh,
Medicine.
okay. Yeah, okay.
How many people have joined, Priyanka?
Yeah, so we have 53 right now with us.
Okay.
Yeah.
Welcome to the doctor's web
Yeah.
on Sunday. It's tough.
Yes, yes.
I'm surprised even 53 showed up.
Yeah, for a Sunday morning, 53 is a good number, sir.
It's a good
Actually.
number.
I think one should start because with the intros and all, otherwise it'll get the people who are
Correct.
sitting on time, then they don't like it that why am I
Like they're just
Yeah.
sitting there.
Sure. Yeah, I was actually about to ask all three of you. Yeah, so let's start, sir.
Yeah,
A
yeah.
very warm welcome to all the participants joining us today for the webinar, Underdiagnosed, Undertreated and Understanding OSA in Women, presented by Tevas Life Sciences. And I'm Priyanka, and I'm your host for the today's session. And on the behalf of Tevas, I thank you all for joining us for this webinar focused on women's sleep health and awareness around the OSA. OSA in women often remains undiagnosed and undertreated because the symptoms can be presently different from the commonly known OSA. So, through today's session, we will be able to understand the awareness around the early identification, timely diagnosis, and effective management approaches to improve patients' outcome. We are honored to have esteemed panel of experts with us today who will be sharing their valuable clinical insights and real-world experiences. Before we begin, I would request all the participants to post their questions in the chat box during the session. Our experts will address them during the questionnaire session in the end of the webinar. So today we have Dr. Srinivas Kishore, Dr. Manveer Bhatia, and Dr. Shivani. So Dr. Srinivas Kishore is one of the biggest ENT specialists, and he's a very renowned name in the sleep medicine, and he's from AIG Hyderabad. So over to you, sir.
Good morning and welcome everybody. I'm delighted to host today's webinar and thank you Priyanka and Tevis. Um, Today's webinar is going to focus on something which is increasingly important but often unrecognized, which is obstructive sleep apnea in women. All these years, we've been basically looking at obstructive sleep apnea through the lens of a male phenotype, wherein you are actually looking for snoring, obesity, witnessed apneas, excessive daytime sleepiness, so on and so forth. But women present very differently. Women often present with symptoms which are totally different from how men present, and there are valid reasons for this. Women normally present with symptoms such as insomnia, fatigue, early morning headaches, so on and so forth. But as a society and as a culture, women are not expected to complain. Women are expected to work, come back, and not complain. And I think it's about time we speak about this particular phenotype, why they present the way they present, and we will also sort of delve a little bit deeper into special phenotypes in women obstructive sleep apnea, that is in pregnancy, which is becoming increasingly popular nowadays because of, again, us not recognizing it, and a whole different phenotype, which is women in the perimenopause and menopause age group. And to take us through this very nice topic and to discuss further, we have two very eminent speakers today. And I take this opportunity to basically introduce my panelists, and very proud to introduce Dr. Manveer Bhatia to start with. She's a doyen in this field, and not that she needs any kind of introduction. She's been in this field and talking about this for over 30 years in this country. She's the director of Neurology and Sleep Center at Delhi, and now the vice president of Indian Society of Sleep Research. Thank you very much for accepting to come in for this very nice topic on a Sunday morning, ma'am. Thank you. It's an honor.
Thank you so much for looking forward to this.
My next speaker is Dr. Shivani Swami, and she is a senior pulmonologist, again, not new to this field. She's been in over 16 years in the field of sleep medicine. She's presently the secretary of Southeast Asian Academy of Sleep Medicine, with over 16 years of experience in this field and with a specialty in the management of sleep disorders, and especially sleep disorders in women. She's presently working at C.K. Birla Institute in Jaipur. With that background, let's take it further. And I would like to start off with a very basic question. And I would like to ask both of you, but first I would like to ask Dr. Manveer. Now, first question I would like to ask you, ma'am, is OSA in women often remain undiagnosed and often diagnosed later than in men. And why do you think that is so? Why is it so commonly unrecognized? Where are we going wrong?
Yeah, I think a very important topic on the whole, Dr. Srinivas, and exactly as you said, that women are underrepresented, underdiagnosed. And in fact, the science and data says that about 90% of women with this condition are not diagnosed properly. So just let's go over briefly as to why this diagnosis is being missed. So 2-3 main reasons, which was talked about earlier, but we'll re-emphasize. One, the symptoms are very different. They do not, so it's like a bias when we as physicians or patients themselves, when they come forward, males' common symptoms are very loud snoring and increased sleepiness and obesity. But in women, the symptom is broken sleep, fragmented sleep, neend aani rahi, neend breaks a lot. So that's one part. So they come as insomnia, which is often said, oh, that you have too much going on in your mind and maybe you are stressed and, on things like that, and it is pushed under the carpet. Second is they come with a symptom called fatigue. Now, fatigue is a very non-specific symptom, and very often, again, it is pushed that maybe it's a vitamin deficiency, and many people are treated for very long with that. Third, they have these headaches, low mood, anxiety, depression. So these are the common symptoms. And as, like I said initially, that when we have a bias towards those symptoms, when somebody complains of this, we don't pick it up. So that's one part. Second part is the scales that we have, whatever we have, like screening questions. We have something called a stop bang, we have ESS. They have not been actually validated for women. And stop bang, interestingly, has one question about if you're a male gender, you get a plus point. So in any case, if you're a female, you're getting a 0, but that score should not be right. So I think these are the 2-3 main reasons. Symptoms are very different. Screening questionnaires are not existent. And that's why they are getting missed for the diagnosis.
Thank you, ma'am. I think that was sort of in a nutshell. I think we'll dissect this particular thing a little more as we go on. I would like to ask Dr. Shivani again the same thing. I think ma'am was speaking about a selection bias and all the questionnaires that we were talking about, Dr. Shivani. Uh, the very two common questionnaires that we use in this sleep medicine realm is the Epworth and the Stop Bank. And if from your experience, I think where do you think is the selection bias coming in? Are we selecting the screening tools wrongly? Where do you think we are going wrong?
Um, so at the outset, I'd like to thank you for inviting me. And so I think ma'am has extensively covered all the reasons why women are underreported and underdiagnosed. And I do think so when we talk about the screening questionnaire specifically, so the Epworth sleepiness score is actually nothing but an assessment of the level of sleepiness. And as ma'am had already said that in women, sleepiness is actually not even a symptom. So even if we subject these patients to the Epworth sleepiness score, we are going to get a low reading, and we might end up thinking, okay, these are not, subjects to be screened for sleep apnea. So I think that definitely adds on to the bias. And as ma'am had said, stop bang. So I also feel that snoring is something which is considered very unladylike. So a lot of women would probably not even report snoring. And a lot of women who are overweight are also skeptical about their weight because, of the social structure that we have around us. So they are also hesitant to report to a healthcare facility because it has been fed to them that your weight is a problem. So women do not really want to come to a healthcare facility to talk about themselves, and more often than not, even when they come, they are not accompanied by their partner. So even a lot of symptoms are even missed because nobody, the bed partner is not reporting those. So I think all these biases also does play a role.
And I think culturally, a lot of biases sort of come out. I mean, we are a very conservative society. And like I was saying earlier, I think people don't even come in, and the things like neck circumference don't even matter in women. So I think that's a selection bias. So people just fall off the radar, and what the mind knows, the eye see, and so sort of mimic. I think that sort of brings us very to this very interesting question about the pathophysiology. So I think because the presentation is very different, so let's dig a little deeper into pathophysiology. And I'd like to ask Dr. Shivani this time first. Um, in terms of pathophysiology, because the presentation is different, how is women in the pathophysiology very different in women when they present? And what is the underlying mechanisms that are different?
So, sir, I think we need to understand that women are built differently. The anatomy is different. So, to begin with, as a pulmonologist, first thing I would say is talk about the airway. They have a shorter airway compared to the male counterparts. So, because of the shorter airway, there are also the hormonal influences that are playing a part. Second thing, that they have a lower lung volume and a shorter diaphragm as well. So both these things also play a role. Now we need to understand that in a woman's life, there are a lot of physiological changes which are occurring, which also play a part. So for somebody who is in the menstrual age group, so for them, progesterone and estrogen also provide a protective mechanism for these ladies against obstructive sleep apnea because they're respiratory stimulants. A shorter airway also predisposes them. So when they do actually have obstructive sleep apnea, women would present, not just present differently, they would also have a different features on the sleep study. So when I say that, it means they would have lesser apneas, they would have more hypoapneas, they would have more RERAs. So if we are subjecting these ladies to a level 3 sleep study, which is comfortably done at home, we are more likely to miss it because it is not recording the RERAs. Women are less likely to have supine apneas. They are more likely to have apneas in the REM. So all of these things we might end up missing if we are doing a level 3 study. So then also pregnancy and the various cycles of menstruation, whether the patient is pre ovulation. So all those things also make a difference in a lady's day to day sleep pattern. In general, women have a poorer sleep pattern. Their sleep latency is more. They are anyways, they have more arousals. I think they have increased shortwave sleep. So these all of these factors make sleep in women a very very different parameters to assess. And when we classically just look at the AHI, we might as well underestimate in a lot of this population.
I think we will come to that because AHI and
It's
the metric that we use to be, I think we will discuss that a little later. And I think a little bit also about how the weight is distributed. Usually, when we see a man in our practice, we usually see a lot of parapharyngeal fat pads, a lot of visceral fat, which I think is completely missed in women. And I think that's a huge game changer in how I think women present. And I think Dr. Shivani was bringing up this very nice point, Manveer ma'am, that I would like to bring it to you. And you also sort of brought this up. When we talk about the symptoms, and the first three symptoms that you actually said, fatigue, loss of concentration, all these things. So, when we come to sleep and the CNS manifestations, and so what are we talking about here, ma'am, when it comes to sex differences in the sleep characteristics from a CNS standpoint? What are we really looking at?
So I'm not able to understand. So I think basically we are trying to understand why do they get this symptom of break in sleep.
Correct.
To go symptom wise. So the break in sleep is coming because they have more of this REM OSA. So very
Uh-huh.
often they will say that I sleep okay, I take a little while, but it's always breaking at 2 and 3. And I have numerous patients who are actually on some sedatives or simple word sleeping pills for this reason. But the sleep will again break at 2 and 3 because that's the time that when we are in REM sleep, there is a more variability in this airway. The airway collapses more and their arousal threshold is different. So it breaks. So once it breaks, yes, they're not able to go back to sleep. So that's one part. Then they get up with this feeling that they are tired and morning headaches. So this is well known that, because of this gaseous kind of exchange, which has not happened, they will get up feeling with a heavy head. And very often in neurology practice, then we either treat them for tension headaches, or we also have an entity which is migraine headaches. But migraines can also get worsened with poor sleep because of any reason. So there is a big overlap from the neurological conditions to these symptoms which come in. I've also seen a lot of women with fatigue, sleep apnea, but diagnosed very often as fibromyalgia. They have lots of aches and pains, and these are very ill-defined aches and pains. The whole day the body is hurting, and as a result, they are in bed. So this is like a vicious cycle. Then they get, as diagnosed as fibromyalgia. So I think the symptoms are very complex, and the symptoms are unique to each individual because of, like Dr. Shivani mentioned, they have a different airway structure. There is more of REM OSA, arousals are very less, a threshold is very low, and their whole, to put it simply, the respiratory responsiveness is very different. So the presentations are very different.
So I know we have like a mixed audience here with different levels of understanding, but I can't stop myself from asking you that is there an issue with the arousal threshold in women, and is that why all this is happening?
So you're right. So there's a mixed audience, I believe. So what is arousal threshold? Arousal threshold is kind of, let's say, a line where something in your body and it wakes you up. So in men, this threshold is higher, meaning it requires a lot more things going on to wake them up. So the apneas are more clear, or the breathing pauses, if we were to put it simply. They become longer, and that's why you see when you do a sleep study, you will see a typical pattern. Women, we are saying, have a low threshold. That means little bit of an impairment in their breathing, their sleep will break. So they have very frequent, short, mini breaths, as we call them. And this is what results in this overall feeling of not being rested and just feeling that I am having poor sleep. Most of them will just come and say poor sleep. And like Shivani said, you repeatedly ask a question about snoring, and then they'll say, I'm not very sure. But later it might come on, and yes, okay, there is some snoring. But the first dominant symptom is poor sleep because of this
So,
arousal issue.
so the question now is, if you are getting most of these patients with fibromyalgia and chronic fatigue, and I've seen prescriptions from neurologists with TCIs and tricyclic antidepressants and SSRIs, and so what is the role of these medicines and what do they do to sleep apnea?
So, in fact, they would kind of worsen the whole physiology, as we call it, because most of these medicines are also causing weight gain. I just saw a lady yesterday on, she came with the problems and feeling low, continuing to feel low. She did have some personal issues, but she was started on escitalopram and given some anticholinergics, and she's gained 10 kg. And she's come after 2 years and she's much worse. The whole body is hurting even more. So weight gain is a big issue. Secondly, if they are given some kind of sleeping pills, etc., it will alter their thresholds and their apneic events will become more, and they will actually feel more tired. And when they feel more tired, they again go to the physician who increases the medications. So it becomes like a loop that we are actually in a way. So simple thing is we just should go back and ask, how is the sleep? And that will be a clue that something is not right. It's beyond just a tension headache or a fibromyalgia.
I think again I would come back on this because I think clinical presentation is very important, and we'll spend a little more time on this before we jump on to diagnostics, Dr. Shivani. So if all this weight gain is coming in, and especially in the reproductive age, we'll talk a little bit later about perimenopause and menopause, which is of course which is the elephant in the room. But um, how often is obesity hypoventilation syndrome an issue in women? Do you see that often? Do you see that in our sub of in the subcontinent? Or how do they present?
So, sir, unfortunately, we see these women a lot, and we do not somehow see them in the OPD. They usually land up in the emergency room with acute and chronic type 2 respiratory failure. And even if they've been to multiple healthcare professionals, the usual diagnosis that they have is obstructive airway disease for which they are being treated, and nobody's actually looking at the OHS or the OSA component of their problems. So it is very often missed, and these people land up in the emergency room, and that's the typical presentation that at least I see them with. So I think 90% of my female patients who present with OHS are not in the OPD, but in the emergency.
And how often do women present with, like we see the men phenotypes typically presenting with resistant hypertension? Do you see that in women? Do you see arrhythmias and resistant hypertension in women? I think the question can be from both of you.
So I see a lot of arrhythmias in women. Resistant hypertension, I think still in women, I don't know how well they record their blood pressures at home, how conscious they are of the BP being monitored. And I think they also have this mechanism where they keep telling themselves that a systolic BP of 160 is because I've just presented to the hospital. Oh no, because I had eaten a little bit more salt that day. So I think women have a different mindset in our country of pushing their symptoms and diseases under the carpet and not really looking after themselves.
I think that's also very, I mean, it's a very cultural sort of thing that so that sort of takes us into the realm of diagnostics. And I think I really require both of you to sort of help me with this. When people present with these sort of very non-typical symptoms, which now we know are typical and we are not asking the right questions. So typically, I think you did mention this fleetingly in our discussion before. So, what kind of investigations would you like to order for a patient typically who come to you with these symptoms, which are vague, like fibromyalgia symptoms, chronic fatigue, early morning symptoms, poor cognitive, impaired cognition. What kind of diagnostic sort of a repertoire would you like to take this patient through? I'll ask Manveer ma'am first, and then we'll come back to Dr. Shivani.
So I think we should start with just the basic, like we always do, like the routine investigations. We've not talked about one another entity, which is very common in women, is the restless leg syndrome. That is just like this extreme in one line. If we were to say, there is a discomfort in the legs, mostly coming on at bedtime. They just want to massage or kick, or somebody has to rub them, or they get up and walk. So that's this big entity. It's more common in women. And this also gets missed because they all only come and say that I can't sleep, but you have to dig deeper and get it out. So coming to the investigation, so this we start looking at just their normal complete blood count. Hemoglobin may or may not give an indication that yes, and these women sometimes are either having menorrhagia or they've had menorrhagia in the past and they're still running on low hemoglobins. And there are some other parameters in the CBC which can show you. Then it's a good idea to do just the normal liver function test, etc. Like anybody else, they are prone to develop metabolic things like fatty liver, etc. You also look for, in addition, the iron studies. They will have low ferritin, low iron, low saturations. The vitamin tests, again, are very important. So I think those are the routine blood workup and thyroid test and fasting sugars, cholesterols, because it's also been seen that if they do have sleep issues, their risk for cardiometabolic is pretty high, which is getting ignored. So we need to pick them up and treat whatever the other things. Coming to now to the main thing, which is a sleep study. So which kind of a person, which kind of a study, what are the indications of a study? Is of course, if you are suspecting sleep apnea, definitely. But if also, again, because of this threshold of a low threshold, that people who are just complaining of poor sleep for years, taking medications, not sleeping well, I think those people should also be evaluated with a sleep study. Sleep study, as we know, for in people who are also not medical, there is one we call, like what we just simply use a term called complete sleep study, in which you have sensors on the head, face, breathing, respiratory movements, oxygen, legs, etc. And then there are some which only measure your breathing and oxygen. And now there are some which are like devices, which can also tell you REM OSA, sleep issues, and saturations. So I think, I personally feel in practice now, looking at the individual, if somebody has a lot of insomnia, like I can't sleep, my sleep is very poor, if you touch me, I cannot sleep, and especially this entity which we can also talk about called COMISA, that means is comorbid insomnia and sleep apnea. You try and do a full sleep study in them, the sleep will not come. So for them, I usually then either offer a level 3 or the ring that I have, which is the balloon ring. So then it picks it up. But yes, if negative suspicion is high, then you go backwards. But there are some who say, no, no, you can do the best. So I think we need to tailor it to my patient, is what I'm saying, depending upon understanding, because we need some sleep to get. So those are the kind of tests. So routine biochemical, as always, and a sleep study, but tailored specifically to the individual. Like if you have a pregnant lady, she's about 33 weeks. I just recently saw 33 weeks. She's absolutely not comfortable in any position that she's lying, but the husband has noticed very loud snoring, choking, and there's tachycardia. She can't walk. She's breathless. Cardiac evaluation is all okay. but we had to evaluate her to get an idea that is there sleep apnea or not. So can't do a level 1 study, can't do a level 3 study because she's just very uncomfortable with the belt. Then we had to give her this ring, and which has come positive and suggestive of sleep apnea. So I think tailored, kind of specifically tailored to the individual.
Dr. Shivani, I think it's your turn now, and my question to you will be a little different. In the era of wearables and nearables, which now have become like almost standard, and I think ASM is also recognizing it, and all the bodies in the world are because I think we have to be practical in, as ma'am said. So are you seeing that, of course, the modern women, of course, are all with gadgets. Do you wear one?
I don't.
Okay. What is your experience with the data that's coming from wearables, and where do you see that in our present context? And of course, how much trust do you put in these devices, and where do you draw your line?
So, sir, I think that's a very in question which everybody wants to know. But as for me, I'm sure everybody might have an individualized opinion on this. I think the wonderful thing that has come out of these wearables is that people are talking more about sleep. So they're definitely more aware of how they're sleeping, how their parameters have been when they've slept. So that is definitely, the awareness is much more. And the number of walk-ins to the OPD, even from women, have actually increased, saying that, I have not been sleeping well, I have this issue, I have that issue, and all of that. So it's my deep sleep is not enough. All of those things they do actually come up with to the OPD. But how I look at this data from the smart watches and all these things is practically as a screening tool. I do not at any point consider this diagnostic. Of course, I look at their pattern and it's simpler for me to explain to them, that there is a problem and we need to go ahead with further testing or just reassure them or suggest lifestyle changes or whatever. But it definitely does remain just a screening tool for me.
All right. So if the wearable sort of flags out something, um, if you have so based on the age group, and I think me as an ENT surgeon also see a lot of teenagers with very similar complaints, which is resistant hypertension, weight pains, and especially something that we've also not discussed is TMJ. And we see that a lot. Patients coming with ear pain, and you look at the ear, and there's just nothing, and then you touch the TMJ area, and they just wince with pain. And this sort of snowballs into having, hemicranial pain, and then it goes into chewing issues, so on and so forth. So, especially for this kind of a phenotype, if the wearable does show and flag out something, what would your next algorithm be? How would you take this further?
So I usually don't see teenagers, sir. I don't do pediatric practice at all. So sorry. I think ma'am can probably talk about this.
Sure. I think
Yeah.
then maybe, ma'am, I just want to know out of curiosity as to
Yeah, so
because we've
I
seen
just
that.
wanted to add one more thing to the wearables. So when I'm talking about the ring, I'm talking about the balloon ring, which is a
Right,
US FDA approved device for sleep apnea. So I think
right.
the wearables, so one are these health trackers, as we call them, and then are medical devices. So every day, if you follow the US FDA, they are approving one device. The recent one has come like a patch, like a sonar thing, which is they're saying is going to pick up the sleep stages. So I use that a lot because especially in the women and especially this because of this comisa. So that's one part. So, and that has been validated for the with the against a good PSG. So we know it's about 85-88%. So which is pretty good for me. These teenagers, so teenagers coming with some poor sleep is your question.
Yeah, poor sleep manifesting again very differently. Just migraine,
Yeah.
uncontrolled
So
migraine. And
I normally then spend just a lot of time in their history to understand their weekdays, weekends, philosophies, their daily routine. So they uh, change their study times according to which they take their courses accordingly. So I think again, I spend just to try and understand what is really bothering them, what is it that they are doing wrong in those 24 hours, and how we can help them to go backwards. Unless like they are obese, and really some of them have obesity with this very severe delayed sleep phase. They are sleeping at 4, eating junk, have touched 120 kg. I mean, those are very hard cases to actually, and then they have very high comorbid psychiatric problems. The depression is very high. There's bipolar. There's also this borderline personality disorder, which I've read a lot, and my patients have it. So those are very hard cases, honestly, to manage. Some of them have slipped through. We do try and call them back, and then if we do need a sleep study, what do we do? So, like, I have started doing two things for them because they are sleeping so late. It's not possible to tell them to sleep at a proper time. And if you stop the study at a conventional time, they have not slept. So, either I have to, I'm again giving them the ring, but I give it for 2 or 3 nights. So, I get some information back. Or I make sure that if I'm able to send a tech, like yesterday, we've done a 140 kg. I mean, that's a male, but the thing is that he sleeps at 5 and it is a shift work. So he cannot. So then I had to tell him that you will stay till longer and you will get 2 offs type. So we in occasionally have to manage what to do because to help them, whatever their sleep timings are. Tough.
Dr. Shivani, before we jump into two main issues, I think, which is perimenopause and menopause, I quickly want you to touch a little bit on the overlap syndrome situation in women. Is it different? Is it the same? How do you manage this?
So, so
COPDs and OSA.
So, sir, I see a lot of COPD and OSA. I also see a lot of ILD with OSA, actually. That's also something which is under recognized. So, I think those are two situations where I see a lot of overlap with OSA. And I think what is challenging in these patients is that their pressure requirement when you put them on PAP therapy is actually not very high. They don't tolerate higher pressures very well, probably because of the shorter airway and all that. So I think that becomes a challenge for us to titrate those patients on an adequate PAP therapy so that they're able to tolerate it well and the compliance is better. I think that's my challenge.
So I think this brings us to the one of the most important topic, which is pregnancy and followed by perimenopause and menopause. Ma'am, I would like to I want both of you to sort of let me know about um, when would you flag out OSA in pregnancy? What symptoms do you see? And of course, you did mention a little bit about the challenges in diagnosis, because I think this is something that our obstetricians are not sensitive to. And the problem is also with our teaching. I mean, 1/3 of our life we are spending in sleep, and there is like 32% of Indians have sleep apnea. And I think in our curriculum, whether it's post graduation or in super specialization, there's hardly any mention in terms of these special cases. And I want both of you to sort of throw some light on the challenges in terms of diagnosis and management in pregnant women. Dr. Manu, you can go first, and then Dr. Shivani will go ahead.
So I think, yeah, very, very important topic. And especially, we are trying to do a lot for the mother and for the child. And this is one sleep fits into both the sides. So obstetricians, I think, agreed should take care. Firstly, we have a lot of data and science and research which has tracked the women from first trimester to third trimester. So one thing which needs to be emphasized is that keep asking the question repeatedly. So if you asked for a question initially, like are you snoring or excessively tired, then you have to keep asking every visit because it will change. It's seen that about initially, suppose maybe 5 or 10% will have sleep issues, or sleep apnea, by the time they touch third trimester, it might become 20%, 25%, which is very
Quite
high.
a high percentage.
Very high. And because of the weight, the nasal hormone changes, etc. So those are the causes. So that's one thing which is very clear that we should keep asking. Second is, I think what we're trying to say that not every person who comes into for a pregnancy and obstetricians have enough that you start screening them. So what are the red flags that, oh, this person I should definitely get some check? So one is, this is especially obesity, and they were snoring initially also pre-pregnancy, and now snoring has become really loud. Some of them have polycystic, but now it's called polyendocrine disorder. So they are really prone to it. They've had snoring all along. Now it's become really loud and they've gained more weight. Then is if your gestational diabetes has come on. So this is a very high. In fact, it's been seen in these people, it could be 30% might have OSA or 40% might have OSA. And preeclampsia or hypertension, which is not getting controlled. So I think these 3-4 things, at least if we look at, we can identify these people and do something about them in the pregnancy group.
So
And
this,
child, if the child is not growing well, if there's IUGR, and if there's a low birth weight baby, so please again be alert that something needs to be done.
that brings me to this question to ask you, because nowadays there's lots of IVFs that are being done, that we're playing around with hormones so much. So this becomes very important in the first trimester, and also because of different situations where the mother or the expected mother's asked to take a lot of bed rest, not move around. How do you when your colleague, a pediatrician or probably an obstetrician sort of reaches out to you, Dr. Shivani, with this particular question as to, I have an ex kind of a patient who is obese, who probably is in the first trimester, lot of congestion, not able to move, and she's not supposed to move. Now, what kind of sleep study would you do to them? And what would be your algorithm in terms of treatment options for this particular individual?
So, sir, can I just begin with adding that when we're talking about the IVF treatments, we also need to be watchful of females with history of infertility. A lot of these obese women with history of infertility may actually be suffering from obstructive sleep apnea, which could
Even
also
before.
contribute to the infertility as well. However, going to the question now that the first trimester pregnant lady who was conceived through IVF, I presume. So I think I would definitely like to subject her to a sleep study, preferably a level 1. However, since she's not able to move, best would be to maybe do a level 2 at home, depending on the patient's acceptance and comfort. Like Madam said, that is primary. If she doesn't sleep through the night after putting all of that, then the entire purpose of doing the study. So we'll probably have to be watchful and mindful of all of those factors and advise a sleep study to make the diagnosis, preferably a level 1 or a 2. And if not, then the level 3 or one of the wearables, like ma'am was talking about the balloon ring. So I think that is where we would probably begin with. Once we have a diagnosis, depending on what we actually get into the diagnosis, so if there are just more of hypoapneas, I think I would probably like the airway to be assessed with the DICE, and these are women who may benefit from a mandibular advancement device also. So, and if not, if they have severe sleep apnea, then I would really like to try the PAP device for them.
Yeah, I think that sort of tells us the entire spectrum of things. Uh, so now we have just the time to discuss a little bit about the menopause and perimenopause, the symptoms, the association with cardiovascular morbidity, and as we all know, all the cardiovascular, the ISEC trial, the Rickettsia trial, all these trials have women being underrepresented. I think it's important that we speak a little bit about this particular phenotype. Why is it different from a pathophysiological standpoint? Our diagnostic tools and how do we manage them? Manveer ma'am.
So menopause, we've talked about hormones in the women's lives, and from menarche, then pregnancy, then menopause. So menopause sees estrogen, progesterone going. So the support of your airway control is much weaker. In fact, there is studies which have shown that the tongue muscle, which is a big bulky muscle, it actually becomes very less effective and active once the progesterone has gone. So the tendency for it to fall back is much higher, and sleep apnea becomes much more common. Earlier on, before menopause, what I mean is that the risk for males is higher and women is lower, but post-menopausal, the risk becomes same. So if the risk is same, their risk for cardiometabolic problems is very high also, but they're not getting picked up. So that's why it becomes even more important for their risk for cardiac, coronary artery disease, brain strokes, and now we also know memory and cognitive becomes very high. So I think that's the reason that these women need to be picked up, and they are not getting picked up from primarily the main things that we talked about earlier, that why do they remain undiagnosed? One, the symptoms. Second, is just their nature, because they are not complaining people and they don't usually talk about it too much, and snoring is not talked, so they just kind of, and they take the journey. If I have seen many of these post-menopausal women's journey, it's very complicated. They either are self-medicating or taking help from somebody, or just taking some over-the-counter pills, painkillers, sedative hypnotics, but the cause could be sleep apnea. So yes, it's a very, very big problem in the perimenopause to menopause because of the hormone changes.
Uh, Dr. Shivani, I would like to bring in again you brought about ILD, and so how does it change? And when you have a patient with, again, a cardiovascular problem, some heart failure, all these things, and I'm sure you see all these patients. So how different are they in their presentation? How do you manage these complex cases?
So, sir, primarily in presentation, when we see somebody with a COPD or a ILD who has a disproportionate set of maybe breathlessness or, daytime disturbances or multiple nighttime awakenings, has a disproportionate pulmonary arterial hypertension on workup, which is disproportionate to the respiratory diseases. Those are patients that we do suspect of having a concomitant obstructive sleep apnea. Now, primarily, when we start working them up, if they're not willing for a sleep study, the first and foremost thing that we do advise is an overnight pulse oximetry for them. So that does usually give us an indication that they're having a lot of nocturnal deoxygenations, and that is the first sign that actually also makes it easier for us to convince them to undergo a sleep study. So these patients are patients who we do advise PAP therapy, because that does actually not just improve their sleep cycles but also improves their respiratory disease control. So we do always advise them PAP therapy.
I think, what about little bit we'll go into therapy per se, and I think we'll use these few minutes to sort of ask therapy. Well, especially since you brought up COMISA, and which is comorbid insomnia and sleep apnea. Of course, we all talk about CBTI, and in our sort of a country with where these kind of resources are very scarce and very hard to find. A therapist who can actually do proper, not CBT. There are a lot of people offering CBT, but CBTI is so difficult to sort of access. And so, how do you sort of treat these patients with COMISA? I think it's a Pandora's box.
Is for me?
Yes, ma'am.
Okay. So COMISA, yes, is much harder. And if we look at even otherwise data or our personal experience, PAP acceptance is an issue. PAP acceptance in women is even a bigger issue. So they just don't like the thought. They don't like
That was
the,
my next question, actually,
yeah,
to
it's
Dr.
people not interested. Now, when it comes to COMISA, that means they have insomnia and they have sleep apnea. And COMISA is well known in any case that people with COMISA find it very hard to accept the PAP because they anyway sleep is very bad. So even the data and research shows that it's been a lot of dispute, and that should you try and treat the insomnia first, then you add the PAP, or should you do both together, or should you do PAP first and then CBTI later? But PAP first is not a good idea. That's one thing very clear. And I've seen a lot of people who are having that, got the PAP, and they're just throwing it away. So I usually, what I do is I start working on their sleep primarily first for a little while, depending upon the severity. So if it's giving me that it's kind of mild or moderate or just moderate to early severe part, then I kind of help them through their sleep part first, wait for at least 10 days, 2 weeks, 3 weeks, and then gradually introduce the PAP. But yes, if they are very severe sleep apnea and insomnia, then I'm not keen that I keep waiting for them to, they might have some event. So then we can add to these people a small, some sedative hypnotic or an anxiolytic to take care of the arousal thresholds, take care of this acute anxiety episode which comes on at night, and acclimatization with the PAP. By that, I tell them that, okay, use for 2 hours, 3 hours, 4 hours, build it up, don't panic about it. And that's the thing which has seemed to work with most people, that be very patient, do not force one night, and if needed, you take something, but we will withdraw that thing, whatever the additional measure, in about 2 weeks, 3 weeks. So that's how I kind of approach this problem.
I think there are a few questions, I think, especially directed towards you and Dr. Shivani as well. I think we will talk. I mean, some of them would help us to give you more. So, ma'am, for you is under neurology, which is the most common condition which has underlying OSA as a comorbidity? I think that's a question for you, specifically for you.
Yeah, so I think, we recently reviewed it, and I keep like giving talks in the neurology forums and Indian Academy of Neurology as well. It's almost with all disorders, but yes, like I've mentioned, headache is a very big one. And now we have the bigger one is cognitive decline. So we have to be very alert every day. Yesterday, I saw a patient who has cognitive decline. He has sleep apnea. He has fatigue. So, and this has become one of the reversible factors for cognitive decline. So we have medicines coming into the country for 1 lakh injections. So I think we can just ask for snoring and sleep and improve it, rather than heading them to that direction. So I think that's the answer to that.
Dr. Shivani, the question for you is, OSA in pregnancy is gestational. What intervention is needed? I think this question is half. But Dr. Kashmira also says that it's true, Dr. Shivani, ILD patients, it's a special sort of a situation and comorbid condition when treating them simultaneously is very helpful for the patient. This is a very interesting question, and I think both of you can take it one after the other. Many supplement companies are promoting magnesium for sleep and restoration. Can you comment on this?
Shivani can talk first.
I think I do not believe in that, sir. I mean, they do, and I think a lot of athletes are also, subjecting themselves to taking magnesium for better sleep. But I genuinely do not think that it is more of placebo effect, I would feel. Yeah.
And half the magnesium brands don't even cross the blood-brain barrier, and you are giving it for sleep.
But every single person is on it. By the time they come to you,
so you are just producing very
they're
expensive
saying
urine.
that they are better. Like the sleep gets better, but it gets bad again. So it's
So I think
that's where we are.
probably there is a role for people in whom magnesium is deficient.
Yes.
And I think that sort of that's very important. And I think one question for me is role of allergic rhinitis. And I think allergic rhinitis is one of the most important factors that also play a role. One of the most important comorbid factors, and it gets worse in pregnancy, because in pregnancy, in the first trimester, the congestion just gets worse, and we can't use many of these because they're all category D drugs, the decongestants and all that. So there are very few antihistamines that we can use in the first trimester, but lots of intranasal corticosteroids can be used to reduce the, but then one needs to understand that just treating the nose will not cure somebody who has sleep apnea, but it definitely is an adjunct therapy. So I think we've sort of in the time that, I mean, we can go on all day. This can be a whole day webinar because our audience are very mixed. And since we sort of thought we will touch upon the basics to sort of sensitize everybody to the topic, different modalities in the presentation, the pathophysiological differences, the clinical manifestations and the differences, management. We also spoke and touched base a little bit about pregnancy. We spoke about perimenopause and menopause, and we spoke about the different treatment strategies that are available today. So I would also like to say that there are just not PAP, there are other devices also like the INAP that has now come in, which can be also used as a treatment modality for those specific patients, because especially younger women and women in the reproducing age group, I've seen that they do very well with this INAP therapy, and this has been a personal experience. We're still doing some studies on that. So that sort of brings us to the end of this very interesting webinar. I think there are lots of insights, and I think we could do our best in this 1 hour that is possible. Priyanka, you could take over now.
Sure, sir. So, yeah, we're still getting so many questions, sir. So I think the whole session was very interesting. Even I was also going through the whole session, and I got so much of information from all three of you. Sir, would you like to take some more questions? Because we have the questions, sir.
Yeah, I do. From a time standpoint, is that okay? Or
Yes, sir. Yes, sir. We can go ahead. We can go ahead, sir.
okay, so we'll probably just take like 1 or 2 questions. I mean, question for me is, how effective is sleep surgery? Is this for pregnant women or is this generally for women? Okay, so I'll give both. So see, surgery, it's not a blanket term. We don't take every patient and operate for sleep apnea. There are a specific phenotype. There are algorithms that we do. So this is a very general term, but I think I can speak to Rishi about this on a special chat. Drying throat and PAP. So Dr. Shivani, you want to take this?
Yes,
Dry
sir,
throat,
sure.
PAP.
So I think dryness with PAP, because it's giving pressurized air, is quite commonly seen, especially I think in the dry areas like Rajasthan. So we see it a lot. So I generally prescribe it with the humidifier. I think now we have all equipment where the humidification level can be set. So we could increase or reduce the humidification depending on the patient's requirement. So that's the first thing. If the patient still feels dryness in spite of being on the highest level of humidification, we could try using lukewarm water. We could also try using the PAP equipment and keeping the PAP equipment at a slightly higher level than the bed. So I think these things usually together do alleviate the dryness.
I think we'll take one last question, Manvir ma'am. The question is, PCOD is now changed to PCOS. Of course, PCOS, the question, PCOS is now changed to PMOS. And
PMOS.
shouldn't this area of interest be screened further?
Yeah, no, I agree with you. This should be screened. Pregnancy should be screened. Menopause should be screened. In fact, while I was going through some articles, there's a very nice study from, that's the only one that I could find actually from China, which they have come across, and we should maybe do this in our country, an expert panel suggestion for scoring or evaluation during pregnancy. And they've given very nice guidelines and very nice questions which should be asked, and how at the end of it, how people should be channelized, and things like that. So I agree, yes, wholeheartedly, that there is it's a very, very strong and a high correlation between sleep apnea and this metabolic endocrine syndrome that we're talking about. And yes, it needs to be done. But till the time that guidelines kind of come up, I think each one of us can individually start asking questions to these patients we see.
No, I think the biggest challenge has been not to even know and look at everything through the male phenotype. And that has been such a blunder, I think. And that is across. This is just not our country's
No,
situation.
it's
I think
all over the world. Yeah.
across all over. And like so much of, so many patients have sort of slipped through, not because we were not asking the right questions. So I think this is a good foundation for us to start there. And then again, I can't thank you both of you enough to have sacrificed your Sunday to come on to this webinar and sensitize all of us on this very interesting topic. Thank you very much, ma'am. Thank you, Dr. Shivani.
Thank you, sir. Thank you, ma'am.
Thank you, and thank the audience for their interaction and their patient listening, and to Devas as well. Thank you.
Thank you so much. Thank you so much, doctor. I would really thank to all the three doctors, Dr. Srinivas, Dr. Manveer, and Dr. Shivani as well. Thank you so much, Dr. Srinivas, for such a wonderful session, like moderating it so well. And I really like to thank both the doctors as well. Very interesting answers and very, educational awareness. It created a good awareness among us. And thanks to the whole audience for joining us. And the questions which is left, we will definitely answer it to all of them personally. You can write it to us on our website, tevaslifesciences.com, as well as you can reach out to us at any time through our website. And the recording is also available on the website from tomorrow as well. So if anything is missed, anybody wants to listen again, so they can go through our website as well. Thank you so much, sir. Thank you, ma'am.
Thank you,
Thank
sir.
you, Shivani, ma'am.
Good day, everyone.
Thank you.
Good day.
Thank you, everyone.